So I'm very excited, thrilled to be here. Many of the people who I do know around the table have certainly helped my work on a regular basis, so I'm really glad. And actually, your son's subject is, there's about 2 panels in the Genocide Memorial in Kigali on him.
Really?
Yeah, and it's done very well, I think. So I think it would be great to have him there, and for sure he should come. There's a lot of work that has to be done. I tell the story a little differently from the way Renslow said it, in terms of how I got involved in HIV work. It was 1987, after Renslow and Ron had started the HIV clinic at County, but it was actually this woman, whose name is Ida Greathouse, who sort of banged on my door and said, you know, you think you're a feminist, you think you care about women's health. Well, you know, I go to the HIV clinic down the hall, and it's not meeting my needs. I have a kid, I have issues, people are not taking care of my gynecological problems. You know, why don't you do something about this? She was an ex-junkie, she was very loud, she was phenomenally wonderful, in-your-face person, and it was very hard to not respond positively. At that point, you might know or might not that women made up just a very small percentage of people with AIDS, and that has grown now to about 28% in our country, and of course globally more like 50%. In some areas even more. So what we did, though, is what Renzo said. We started a single-site program. We learned about providing comprehensive medical and psychosocial care. Women and children were seen together to sort of help women who cared about their children and would do anything for their kids but wouldn't as much take care of themselves. We had to attend to issues related to drug treatment and mental health issues and violence. And we were able, actually with Renzo and other people's help, to actually incorporate an NIH research program within our care setting. And I think that made us learn even more. So my sense of what happened was that we learned from the women how the women wanted to shape their HIV care. And I'm going to just say that some of the areas that we learned that in was protecting confidentiality, testing older children, knowing about medication side effects, definitely understanding the importance and impact of violence, trauma, comorbidities like hepatitis C and liver disease, smoking, drug use. Most importantly, understanding how women's life situation and their family's life situation influence the need for being flexible and having appointments that made sense, support groups, peer education programs, having the women help the program be successful. And with them, we tried to provide an ambience of caring where women with HIV and their children and their families could actually get the best care. And some of this was at a time before we had medicines to actually treat people with HIV. So it was an enormous amount of hand-holding initially. It was a different time. So then we got resources to actually study as part of a collaboration with other sites, and we looked at domestic violence and child sexual abuse in women in the WISE study. WIHS is Women Interagency HIV study, and we learned what we had seen actually in our clinical care, that over 2/3 of the women had experienced some sort of violence, and 1 out of 3 had experienced childhood sexual abuse. So it was a very vulnerable group of people, and that sort of continuum of violence, as we sort of phrased it, continued in their lives, making them at risk for having multiple sexual partners, trading sex for drugs, money, or shelter, and being actually at risk for more for transmission of HIV. So it was an important issue that had to be addressed. We learned actually, even when women were on antiretrovirals and had the opportunity to take them, if they still experienced history of physical or sexual abuse, that they were more likely to not take their medicines. So adherence also impacted by issues of abuse, also by drug use, which was known already, and also by race, that white women were more likely to be taking medicines that were indicated than women of color. We also saw that the mortalities that we had seen in our clinical care bore out in research, so that there were reasons for the women with HIV that the reasons why they were dying were not always related to HIV. So women with HIV, this is a nice slide because it shows you, I think they gave me this, because it shows you that the trends going down, right? There was a lot of deaths early on, trends go down. This is all causes. But then if you look at the people with the causes of non-HIV, you can't see one of my lines as well, but basically the non-AIDS causes are actually similar at the same rate right now as the HIV causes. So as we got medications and people were doing better with meds, we're still seeing deaths that we shouldn't be seeing, and they're from not other reasons. And they're reasons like violence, reasons like drug use, reasons like cigarette smoking causing both heart disease and cancers, as well as issues related to hepatitis C in people's previous drug use. So in order to take care of women and keep them longevity in continuing, we have to address those non-HIV causes of death as well. Okay, so the lessons we learned from that experience in Chicago at Cook County Hospital was that you needed to deliver, you needed a team, a big team, to deliver the care that Ida Greathouse had wanted us to deliver. You needed to respect both the patients and the workers who were involved in doing this. Hundreds of women did die due to ineffective therapy initially, and violence and drug use. And then effective therapy was great and absolutely extended the lives of many, reduced HIV perinatal transmission, but the pills were not enough. People needed more than just pills available in order to do well. And we were definitely in awe of the strength and resiliency of the women for whom we were caring. So if I think about this in terms of medical ethics, and this is what you're doing here, so you know these 4 pillars, I think the first 3, providing good care, doing no harm, having respect for autonomy, are sort of the easier ones to understand in the context of clinical care and research. It's the justice one that I think is a little bit harder. And recently this has been discussed by Dr. Kirsch, who's the head of the AAMC. And he wrote in JAMA a discussion of how the social justice principles, the social justice issue of ethics principles should be thought about. And he uses Rawls' principles of social justice to get at this. So the 2 principles that he cites are, one, that people should have maximal liberty compatible with the same degree of liberty for everyone. So that sort of says we should be egalitarian, right? Everybody should have what everybody else can have. The second principle is more interesting. He says that the deliberate inequalities are unjust, basically, that's fine, unless they work to the advantage of the least well-off. So if those who don't have are given more in order to get to equity, then that's a reasonable thing. And then he discusses this in the context of health care. For us, he says the inequalities in access and quality health care and the fact that these inequalities do not work to the advantage of the less fortunate show that our health system, he was talking about the U.S. at this point, does not meet the criteria for being just. He says to get towards justice, what providers have to do, in this case physicians, is definitely have a responsibility to address the fundamental medical ethics. And including in this would be making personal sacrifices, joining with others in group actions, sort of a commitment to the political process, to advocacy, to change the status quo. And he concludes that these efforts and corresponding sacrifices are necessary first steps toward creating a society in which everyone has access to appropriate health care. So he's talking about the U.S. I think when we think about this internationally, it's very applicable. And there's much we have to do. And this is a world map that I'm sure you've seen over the years as the HIV epidemic has continued. But the latest statistics show that there's over 22 million people in sub-Saharan Africa with HIV. And clearly, the importance of this map is that the southern hemisphere is where the disease is. The resources, of course, are in the northern hemisphere. Okay, so to refresh your memory, in case you don't have it right now, 7,400 new HIV infections each day. And again, 97% of them in low and middle income countries, many in children under 15, and for those in adults or those over 15 years of age, half are in women, and 40% are between 15 and 24. It's our youth that are infected. So in terms of geography, in terms of youth and women, AIDS is also the leading killer of women. The WHO declared this, I think this fall, November, it says, 2009. But they said a really interesting thing as they made this announcement. They said, we will not see a significant improvement in the health of women until they are no longer recognized as second-class citizens in many parts of the world. So understanding AIDS in the context of gender inequity, sexism, I think is very important. So what did we just learn? I think we learned some of the social determinants related to structural violence that liberation theologists in sort of Latin America took to heart, and Paul Farmer and other medical anthropologists have taken to heart more recently. They say that structural violence is a way to think about basically the social determinants which are structural, which are sort of embedded in our political and economic and social systems, and they're violent because they cause injury to people. So we just went through several of them. We went through geography in terms of that map that shows these inequities, sexism in terms of women's issues, age in terms of children, often throwaways in different societies, and lack of empowerment, very important. But there's others that Farmer and I'm sure you would sort of suggest. Low literacy, ethnicity, racism, we'll talk about this in relationship to Rwanda, political violence, and poverty. So I think it's important to think about global health care and our challenges in this context, because I think it allows us to do more and understand better why there isn't sufficient care and what the challenges we have. I think it allows us to understand it much better. Now, the other thing that I found that I thought was really interesting that just is very important related to social determinants is Michael Marmot, who is an epidemiologist at the University College in London. He chaired the commission, the WHO Commission on Social Determinants of Health, and that summary was released, I think, now about 2 years ago, and I find it very helpful for understanding global health inequities. But here, he actually just chaired a forum on health inequities. This is in England now. We're not doing global, developing countries. This is in England, and the introduction to it was, he said, health inequalities that could be avoided by reasonable means are unfair. So in other words, if we can do something about it, we should do it. Putting them right is a matter of social justice, but the evidence matters. Good intentions are not enough. And he basically, in the February conference that just happened a couple weeks ago in England, he said the following is necessary to reduce health inequalities. We have to give every child the best start in life. We have to enable all children, young people, and adults to maximize their capabilities and have control over their lives. We have to create fair employment and good work for all, ensure a healthy standard of living for all, create and develop healthy and sustainable places and communities, and straighten the role and impact of ill health prevention. But so much of this is related to people's lives, how they live, and the power that they have. So how does this relate to Rwanda? So Rwanda is a very small, landlocked, very densely populated country in Eastern Africa, Sub-Saharan Africa. This is the group that I work with. It's called Women's Equity and Access to Care and Treatment. It's abbreviated as We Act. And the fact that our logo has pills and food is significant and pretty, I think, as well. So the inequity and the ethical contradiction that basically got me to work in this after doing HIV work in Chicago for about 15, 20 years was that associations in Rwanda were interviewed by a journalist, an activist named Anne-Christine Tedeschi, and they told her that the men in jail who raped women during the genocide, purposefully infecting them with HIV, were getting medications for their HIV illness, but the women in their associations were actually dying of AIDS, and there were no medicines. So Anne-Christine Tedeschi came back from writing a book about this and then put out a call to physicians in the States who cared about women with HIV and said, let's go and try to see what we can do about this. To refresh your memories, Rwanda in 1994 There were 1 million people, Tutsis and some moderate Hutus, who were murdered in the course of 3 months. Less well appreciated is, I think, the fact that 250,000 women were raped and infected. Many were infected with HIV during that time. The Hutus actually boasted that they wanted to rape and infect women as an ultimate punishment that would guarantee long suffering and tormented deaths. And it was actually because of this that rape was declared a crime against, rape during war was declared a crime against humanity. Of course, it's continued in Bosnia, in Sudan, in the Congo, but this was the first time it was actually declared a crime against humanity. This is a woman that I saw when we went early on to figure out how to actually fast-track, and it was an emergency situation, fast-track medicines for women who were very sick with HIV. And she's holding that piece of paper, she's holding her HIV test result that she got in 1998, and I'm seeing her in October of 2004. She kept it, hoping for treatment. But she also told us that if you're going to talk about what happened to women in Rwanda, show my picture and tell people what I'm going to tell you. And she proceeded to tell about the particular instruments of torture that were used in Rwanda during the genocide. Some of these were actually knowingly sent by the French. The French were kicked out of Rwanda in 2005 and just reopened their embassy last week. So there's international culpability in everything you're going to be thinking about related to ours as well as others. Here's a picture of the machete scars that she has, and she said to me, so was I infected with HIV because these machete-laced HIV blood-tinged machetes that were used on me, or was it because I was raped many times? And we, of course, can't answer that question, but why I share it with you is not just for the sadness and effect of it, but for you to understand actually how even now the issues that happened during the genocide are just like right at the surface in everybody's consciousness who was in Rwanda during 1994. So the global challenge, I think, about gender-based violence is, of course, rape during war, but gender-based violence is much more than rape during war. We see it in post-conflict rape, in coercive sex and forced marriage, in many countries, in survival sex. And if you take that and you put that with an HIV prevalence, which is sort of in the community, and then you have poverty, which sort of prevents people from actually escaping this vulnerability, then I think you have the reason why there's so much HIV among women and why the transmission is continuing. Stephen Lewis is a hero of mine. He was he's a Canadian who's a former UN envoy to Africa, and he writes about this. I took this picture of him at a demonstration. It was a 6:30 a.m. demonstration in Toronto at an AIDS meeting on women's issues, and he was there, and he said sexual violence is everywhere reported, from Maori rape to rape as a war crime. The phenomenon is by no means singularly African. We live in a world community where the depravity of sexual violence has run amok. In Africa, however, the violence and the virus go together. And yet we lack the laws, the jurisprudence, the enforcement that would give to women even a modicum of protection. He's pretty articulate, I think. So for We Act, we felt that it was sort of a matter of justice to sort of respond and with a human rights agenda to this serious problem of women not getting care. Just contextually, nobody was really getting care in Africa in 2003. The world had decided that it was okay to just give people prophylaxis against pneumocystis pneumonia and not actually give people medications. They were too expensive. People weren't worth it. We could never have the infrastructure to give them to everybody. A lot of excuses were put out. And just in around 2002, 2003, people were beginning to have the resources to actually change that in developing countries. Our approach was, of course, to say that people needed access to HIV counseling and testing, treatment without any obstacles, to treat post-traumatic stress and address the continuing gender-based violence that was present, economic empowerment, food, education for children, which the women absolutely wanted, a general sexual reproductive health rights agenda, and to attend to legal rights to ensure that they would be strong enough and secure enough to continue with their care. So we went through Rwanda, had a lot of focus groups with these different associations. We now learned an enormous amount that the prevalence of HIV in Rwanda is low compared to other sub-Saharan countries. It's about 3% generally, and it's about 10% in some of the urban areas. That compares to, say, South Africa, where it's 25%, Botswana, which is 25 to 40%, Lesotho, about 40%, overwhelmingly high numbers. The population is over 10 million. It's a young population. The majority is still Hutu. I'm not going to dwell that much more on, but we could talk about it afterwards if you'd like, about the ethnic issues that are present right now. It's a very poor country with most people living on $1 to $2 a day. And infant mortality is very high. It's 97 per 1,000. Do you know what it is in our country?
23 or what?
It's 6 overall in the U.S., but you can see our disparities. But whites at about a little over 5 and over 13 for African Americans. So we have our own issues, obviously. And if you look at where we fit in, like, the world's, we're sort of under Cuba, under Hungary. We have a ways to go, actually, also to deal with infant mortality. But it's overwhelming to think of 97 deaths per 1,000. It's really ridiculous. The barriers that we learned from the women in these focus groups was that they were concerned about being tested, and they felt that there was a lot of stigma and shame. They were especially concerned with having to retell their stories related to the trauma that they'd experienced during the genocide. They'd rather have people who knew them, who supported them, who were nurses and trauma counselors to be part of sharing their stories and getting their care. So our model, our approach, was to provide women-centered, holistic HIV care without financial obstacles, no co-pays, helping with logistics, giving people transportation money, to respond to the patient's needs and the demands of the members of the associations that called us in, and we now connect with about 27 partner associations that guide us regularly, so we do the right thing. And the women actually did want research to answer some of their concerns about their health. Our clinical program is Rwandan staffed. We start with some community-based HIV testing, provide HIV primary care, antiretroviral therapy, coverage for hospitalizations. We have 2 clinic sites. One is in the center of town and one's a little bit more rural. We have about 3,600 patients in care right now, and over 1,400, because it's indicated by their CD4 count, have been started on antiretroviral therapy. Everyone in Rwanda, as opposed to in the U.S., everyone who's HIV infected in Rwanda gets trimethoprim sulfur. That's the prophylaxis, because there have been 1 or 2 very small studies that show that people in developing countries who take sulfur, even when it's not indicated by their CD4 count, do better. So Rwanda has everyone, so it means a lot more visits and a lot more medicines that get used. So this is what the program looks like. We test people often in their their community settings, as well as at the clinic and where the partners associations are. And we've tested a lot of patients, a lot of people. This is the modern in Centreville clinic in downtown Kigali. This is the more sort of rural one outside of Kigali. This is where people stay if they have fever or diarrhea, short stays for 48 to 72 hours. And this is a patient who had TB as well as AIDS, very low CD4 count. She had pericardial effusion from tuberculosis, and it was she needed to be hospitalized. She refused at first because she had to go home to take care of her kids, same issues that we all see. But then she did get hospitalized, and there were often 2 patients to a bed at this time because of how many people were in these hospitals. This is what she looked like literally 4 months later. She'd gained 25 kilo, like about, she looked great. She was on meds, TB meds, as well as antiretrovirals, a good success. So we learned that you could help people with the pills, but you know, when we thought about it, and we didn't actually have to think, we just had to hear what the women were saying, it was not at all sufficient to give people pills. And a sort of ethical approach to HIV care for women required a lot more. So food, the first thing people said when we gave them medications was, well, I feel a lot better, and now I'm really hungry, and I want to eat, and I don't have anything to eat, so, like, take back your pills if you're not going to give me food, because I don't want to feel this hunger pain. I just, you know, I'd rather die, is sort of what they were saying. And so we had to figure out ways to get food, and we did. World Food Program things, but we can't solve that problem. It's very, very large. Food, and because of gas prices, everything's even higher right now. Very, very problematic. And there's this whole litany here of like mental health services, domestic violence intervention, pregnancy and perinatal care, poverty, income generation, other diseases like cervical cancer, youth support, dealing with stigma and empowerment. So I'm going to show you pictures that reflect each of these things that we sort of try to deal with. Quickly, hopefully, so we can get to another approach. So this is a very sad woman. Her T-cell count was really good. It was about 800, but she was very sad because she was pretty depressed. We found a very high prevalence of PTSD and depression. You can see here almost 2/3 of the women had post-traumatic stress scores that were high with symptoms, and for screening for depression, over 3/4. Not surprising, considering, I think, what people have gone through, but very important for ensuring that their quality of life, their retention, their adherence to therapy, etc., is good. This is what she looked like on the right about 6 months later. You can't quite see it, but she's holding the leg of a doll, that's halfway stuffed, which is part of an income generation project you'll see better pictures of later. So gender-based violence, still very prominent. This is a survey we finished just this past summer. 414 women were screened in our clinic, and 62% reported a history of violence. Does that sound familiar? Remember the first slide I showed you for our U.S. study? It was 62% had experienced violence, lifetime prevalence. This is unrelated to the genocide. This is gender-based violence not related to genocidal violence. Some of the examples they gave was that their husband were refusing to go for their own HIV care, but they were taking the medications of our patients from them and taking the pills themselves, so that the woman no longer had her medications. Unclear, you know, what stage this men's illness was at and what they needed. I don't really know where to put that as emotional, physical, or sexual abuse, but it's clearly abuse. Or more common things like husband withholding money for food or rent. So we did this survey, and then, you know, the people in the clinic said, so what are we going to do about these women with this problem? And so the thing we can do is there are support groups. We can open up support groups, and they filled up right away. We filled up 3 support groups with 62 women going, and 80% of those women still lived with their abusive partner. And they said to us, well, could I just bring my partner for you to talk to them also, to the facilitators of these support groups, because maybe then it would help. And actually, the men came, and the facilitators of the support group started a new support group for the men. There's 34 men in this support group. I usually get asked questions like, so what do you do for the men? And I sort of say something under my breath. I don't know, like I don't really want to do anything for the men. I don't know. But actually, the staff in Rwanda figured out a great thing to do with the men. And actually, 5 of these men have now registered for the clinic to get their own medications, to stop taking their wives' medicines. And I think there's possibility then, if we actually address in many other ways besides support groups domestic violence that women are experiencing, there's a possibility that women will acquire better negotiation skills, that they will actually understand that the cultural violence can be stopped, that it's not just normal that their partners abuse them, and they don't have to accept that. So we could reduce abuse, probably have more peaceful households, and the thought about having more men enroll in clinics all over Africa and other developing countries in other continents would be very important, because I don't know if you realize this, but in many, many, many developing countries, women go for care, and there's fewer and fewer, and there are not sufficient numbers of men in terms of who has the disease actually seeking care. So this might be one way to do that. This is a woman who...
Do you understand the reasons for that?
I think it's because women in general are often connected to care. Women are tested for HIV at perinatal, at pregnancy. So there's a lot of things that push. For us, we started with men having HIV because of gay men, and then hemophiliacs, and then IV drug users. So there was always a larger number of men who were in care. But that's not the situation in countries where sexual transmission is the major issue. And also, since women do connect more in general with care, that could be part of it. But it's a big problem with figuring out how to get actually men to take their HIV seriously and to go for care on a regular basis. This is a woman who was pregnant, who was the first woman we tested at Nchanga who tested positive for HIV, and we approached her to become a peer to help other women. Luckily, she accepted. She was pretty shy then and really hadn't done this before. We pay her, and she's really blossomed in this role and helped, this is one of the groups she holds with other women to ensure that they get tested, and women do during pregnancy in Rwanda regularly. It's very high rates, and women take medications, and our rate now of perinatal transmission is basically nil. There are children who become infected through breastfeeding after 6 months of age because of lack of food, but we're not seeing it through early transmission. Okay, so just to give you a sense of living conditions, many women are widowed. Again, $1 to $2 a day that people live on, not much electricity, running water or food, and education for most of the women we're seeing is about 6th grade level. That's improving right now in Rwanda for the younger people. A lot of challenges in the families.
Sorry to interrupt. How many kids on average do women have?
6. 50% of the children eat less than one meal a day. Most don't have enough clothes. A lot of orphans. 17% of the children we see in our program are orphans. A third of them have lost at least one parent to HIV. School fees are an issue related to education. There's depression that is sort of pretty prominent, noted by the parents as well as by providers. There's a lot of older youth issues related to disclosure and sexual abuse that I'll dwell on a little bit more. This is one of our peer educators. Her name is Floride, and she's holding her youngest child, Annalise, who is infected. The older two are not. Grandmothers play a very important role. This is a grandmother these are 9 of her 11 grandchildren. The 2 boys to the right, lower right, are the ones we see in our clinic. Both of them are infected. All of her children have died, 4 from AIDS, 4 from the genocide, and 3 from other causes. So she's responsible for this. It's a common scenario. Play is very important. We celebrate, I won't go into it, but Day of the African Child every June 16th to sort of give the families an opportunity to celebrate being alive and each other. We also have a Sunday support group where 250 kids come every single week to play and to get a nutritious meal. Here they are listening to a sort of famous musician in Rwanda. Sometimes the activities are organized. Sometimes. And then the older youth we found have really some very big issues related to not disclosing in their family that they're infected, probable history of incest or sexual abuse, being discriminated against in school if they're outed for taking HIV medicines, definitely engaging in transactional sex because of poverty and needing to feed their families, depression. And the WHO has said that the girl who has lost her mother to AIDS is emerging as the most vulnerable child in Africa because of the role she then has to assume in that family. So we have a bunch of youth-specific support groups where girls who've experienced sexual abuse come together to try to help each other, and it's facilitated. There's young people who are sort of called houseboys or housegirls who live in the homes of others who are discriminated against if they're outed for having HIV and then lose their jobs. Pre-adolescent groups to sort of increase the empowerment of young girls. Computer classes, because everybody wants to go online. And we've actually had girls from Chicago who were infected go to Rwanda, and we brought back girls from Rwanda to Chicago. to sort of emphasize the issue of youth and HIV in both countries. And it was pretty striking. We made this mural. This is the one in Rwanda. This is the one at the Core Center to celebrate both countries. And they were very, very welcome in Chicago, and of course for their strength and courage to sort of be there and talk about this. Some of them went back and started a high school group and college group to sort of do prevention efforts and messaging. This is a group of young infected girls who are trying to develop their testimonials to share with other schools. And then malnutrition, big issue. We have a program called Sello Soma. Sello Soma is a porridge that's very Rwandan used. It's used by families as a supplement. It's soy, sorghum, and maize, and they mix it with sugar and water, and they eat it, and we provide it for all of the children that we have who are on antiretrovirals, but sometimes the families of 6, we give it for a family of 6, but sometimes they just eat it as their usual food, and then it's not available at the end of the month when it's still needed as a supplement. We weigh the kids, we give them usually their parents come to take the bags. We're seeing about 160 kids that we give Sello Soma to. And then over the course, over 12 months, we're seeing those who have underweight are doing better, getting with the supplement. And then we also try to figure out better ways to do mental health care. There's yoga, which has gotten a lot of international support. Madonna likes yoga, and she donated to us because she liked yoga, and we could use that money for other things as well as yoga. But actually, the patients really like the yoga. They don't love the meditation part so much, but the exercise part is very good in terms of dealing with pain and moving forward, and it's really been a very useful part to the support group. So we do it in the context of our mental health program with support groups and individual counseling as well as the yoga. There's a legal program where legal advocates train association members and patients on discrimination related to gender and HIV, and so that there could be paralegals to arbitrate issues related to property and marriage. It's really very good. The Constitution is excellent. Constitution insists, in fact, that there's 35% women in Parliament in Rwanda, and the rate is 45%. So the Constitution is very good. It's just not always enforced.
How about culturally?
Well, uh-huh.
Among the stereotypes and the stigmas are men
Yes.
wanting to have sex with virgins because they thought that.
Right. There's a huge campaign. I actually didn't put the picture in, but there's a huge campaign against sugar daddies in Rwanda right now, which is older men having sex with younger girls, giving them money. The campaign actually equalizes sugar mommies as well as sugar daddies, which isn't exactly accurate, but it's an attempt. Actually, so culturally, the society is addressing it. It's got a long way to go. I mean, we just see the impact of it.
And in schools as well as you have a lot of education efforts, but it seems to me you got to bring up kids.
Right. I'm on your side. So that, I think, is our ethical challenge, actually. So, and I'm going to get to it in half a second. That's why I'm rushing through your question. This is our income generation program where women, Hey, Dan, where women sort of make things to sell both locally and internationally, and it's made a big difference in terms of these 25 women having good income. We need it for a lot more women. Okay, so I think that my concept of health and human rights, from that litany of things that were not just the pills, it seems to me that to understand the importance of those circumstances in which people live, like we just saw with the women, and work, is critical to understanding health, and that the failure to sort of meet the fundamental human needs of autonomy and empowerment and human freedom is actually a cause of ill health. So without that empowerment, probably even economic growth by itself probably wouldn't bring the improvements in health and education that we would want, even if we begin to relieve poverty. So how do I put this in terms of what our ethical challenges are for this class? One is I hope I've made the case for women with HIV that AIDS in Africa requires consideration of the state of women, specifically their special vulnerability to rape and sexual violence, early and forced marriage, lack of access to education, economic and earning power, and the rights to own and inherit land or property. And actually, I believe that sort of to avoid avoidable deaths of people in poorer countries has to do with the way we organize our affairs in society. And I think the illustration of the link of sex inequality to the AIDS epidemic in various parts of the world, especially Africa, really attests to that.
So, Dr. Cohen, in that first point, you're making the claim from your Rwandan experience, a claim that seems to me entirely plausible, that it's well beyond Rwanda.
Absolutely.
These issues.
Yeah, because this has been, I mean, I happen to work there, but this has been in sort of every country. That actually, there are issues here too, but it's significantly, I think, in African countries. Yeah, I do. And I think, that's why I showed you the quote by, about, what's his name? By Stephen Lewis about how Africa in general, because he went to many, many countries to see this. But there's another way of thinking about some of our ethical problems. And this is one by Mark Weinberg that was published like around December 1st, which is World AIDS Day, in this journal, where he asks, so are we doing two standards of care for HIV? Why are Africans being shortchanged? So that's a very important issue, and I've tried to distill it for you. So he says, so like this first-line therapy in countries like Rwanda or in developing countries is something called Triimmune, which is a combination pill of 3 classes of drugs. It's cheap, produced generically. It includes D4T, 3TC, and nevirapine. But we know we don't use D4T much anymore, right? Because it causes body habitus changes and mutation changes that basically will encourage the resistance of other classes of drugs in the same class later on, which will reduce the ability for people to do well as reduce the ability to reduce transmission of the virus. So we use tenofovir, and it's encouraged, and the WHO actually recommends that people use tenofovir. But it could take years for poorer countries to actually access tenofovir. It costs at least twice as much as D4T. So what do we do in Rwanda? In Rwanda, the protocol is to use tenofovir regimens in new patients who are just starting on. But those that have been on Triimmune are staying on Triimmune and are not being switched. Then he talks about viral load monitoring. So, we check viral load continually, it feels like, in this country, often. And it's important, but it's not routinely available. In Rwanda, it takes 3 to 6 months to get a viral load. They are buying some machines for each province, so that maybe it will be significantly improved soon. But it is needed to show early treatment regimen failure and resistance. You do need viral loads for that. And Weinberg argues that you needed to change medications earlier to prevent mutations from accumulating, which would be very important. And then he looks at initiating therapy early. Are we doing that in African countries? In our country, people certainly start medicines, antiretrovirals, by the time someone's T-cell count is 350. Some people say to even start it at a higher count. In Rwanda, it is now that we start at 350, but in many other developing countries, it's still 200. And many HIV-positive persons, Weinberg states, are coming into care at very low CD4 counts, so that, like, their CD4 count, the first time they enter care or are found out to be infected, they require therapy. But I would suggest to you that actually our model makes it a little bit better, that our experience with community-based model has these associations bringing in people who are infected or getting them tested earlier. So I showed you that our total population is about 3,600, and the numbers for whom it's indicated to be on antiretroviral therapy is 1,400, 1,500. So we're not seeing that and that might be a way for other programs to actually deal with this. But what we are seeing, sadly, from my friend Nyla here, is that when people need third-line regimens, they are just not available. So when someone finishes second line, which is, protease inhibitor like Kaletra, that's it. So integrase inhibitors, newer generation protease inhibitors, not available for our patients. Okay, so that's an ethical issue where Weinberg's arguing, well, how can we give the best care, the same care we give, right? Quality, equity, care. Then there's another ethicist, Ezekiel Emanuel, from the NIH. He's Rahm Emanuel's brother, right? Everybody knows who Rahm Emanuel is. He wrote an article in JAMA, which has actually now been used as a building block for actually the current policies related to international aid. And in this article, they state, that international aid is inherently limited. It's impossible to address all health problems in developing countries simultaneously. It's probably true. Consequently, it is extremely important to consider how this finite aid is distributed. The allocation of international health aid should be guided by three fundamental principles: to save the most lives, to save young lives in particular, and to do so using finite resources most effectively. So you can't really interpret those three principles and say, let's give long-term antiretroviral care for decades to people. He's talking about treating malaria, treating diarrheal illnesses, probably mother-to-child, maternal-child health. It would be part of his list. But it's complicated. I would take issue with Emmanuel's approach here, in part because the money that actually went into providing the emergency HIV care and medications to save people from dying actually weren't taken from resources that were already available. It was advocates, people advocated and fought for new dollars and new approaches to dealing with an emergency problem. Now, I do think we have to think long and hard of how you deal with an epidemic that is now 25 years out. It's no longer, when I went to Rwanda in 2004 to give care to those women and those associations who were dying, we're at a different point right now, at least in Rwanda. Some countries were probably not. So that's something else, I think, to think about. But whether Emmanuel's approach to saying we have to not use these dollars for these kind of people's lives, I think is questionable. I think, in fact, PEPFAR is not keeping up at all. Globally, for every 2 people put on treatment each year, 5 are newly infected. And the new PEPFAR allocations, based sort of on Emmanuel's approach, actually reduce treatment goals to about 320,000 people each year from 500,000, which they were before Obama became president, actually. So he has to do a little better on this. And then again, I basically feel we need a paradigm shift, that you can't think about it that we need the same money that we're using for malaria. We actually really have to think about taking money from other sources that are not providing health for people. And clearly, the $15 billion now needed annually for ARVs can be taken from other places where we're spending them and probably everybody would be happier. But the way Stephen Lewis said it is this. He says, so when is now there's a backlash against funding for AIDS with mindless charges against AIDS exceptionalism? We should find a way collectively to shoot down the pinched bureaucrats and publicity-seeking academics who advocate exchanging the health of some for the health of others, who propose robbing Peter to pay Paul, rather than arguing in principled fashion that money must be found for every imperative, including maternal and child health, sexual and reproductive health, environmental health, as well as all the resources required to turn the tide of the AIDS pandemic. So what are the current needs then in that context? I think they are to expand the developing world's local talent pool of health workers, very, very critical, does require resources, to restore and improve crumbling national and global health infrastructures. Clearly, from my experience, to allow the world's poor to say what they want, and decide which projects serve their needs, and adopt local innovations. And we really do need the resources and the patience to work for gender equity and poverty reduction. It's going to take a long time. I think you need commitment and leadership to sort of do this kind of work. You recognize Nelson Mandela. To his left is Zaki Ahmed, whom some of you might not know. Zaki Ahmed fought against apartheid and then post-apartheid as a gay infected man with HIV. He led an amazing movement to get the South African government to recognize HIV and do something about it. Personally, he refused to take his own antiretroviral medications until the government gave medicines to women who were pregnant to reduce transmission. And he won that struggle, which was great. Another hero is Jonathan Mann, who, of course, was the leader of the World Health Organization Global Program on AIDS initially, and then founded the Center at Harvard for Health and Human Rights. I found this related to dealing with ethics that he wrote that I thought was really interesting. So yet at such times, and he's writing this in the late 90s, yet at such times of profound change, another kind of value becomes all the more vital. And he prefaces this with in this article, in this chapter, by saying epidemiologists spend a lot of time on p-values, but maybe we should spend a little more time on values. And these are the values that he's thinking about to build bridges between medicine and public health and between ethics and human rights. The critical underlying question may be, do we believe that the world can change? Do we believe that the long chain of human suffering can be broken? Do we agree with Martin Luther King Jr. that the arc of history is long, but it bends towards justice? Bioethical pioneers at the frontier of human history, we affirm that the past does not inexorably determine the future, and that it is precisely through this historic effort to explore and promote values in the world for which we share responsibility, articulated in philosophy and in action, that we express confidence in our own lives, in our community, and in the future in our world.
What is this document?
He's edited a book, and it's the last chapter. I can give you the title of it. But I think women all over the world are actually, and people are actually buying this and have been for quite a while. And it's good to sort of think of health people as their advocates in this context. And these are three of the leaders of the associations in Rwanda that called us in initially to sort of help deal with the problem that the women in the members of their associations were having related to HIV. And sort of their elegance and strength is always motivating for me. So I thought you'd like to see them. And that's it. Thank you. Thank you. So, comments and questions?
Yes, the paper is now open to questions. Mary?
I'm puzzled, maybe you can also look at and I missed it. Is there any correlation at all between the incidence of HIV and AIDS and the advances that have been made since the 80s when there was no cure in terms of preventive behavior?
Yes.
I mean, and is that most evident in our own country where we have, we're, okay, AIDS and HIV are no longer untreatable and death immediately sentencing illnesses that we need even to exert greater efforts to avoid its occurrence at all because people aren't self-regulating.
So I'm not sure I know what you're actually asking.
Any connection at all
Between
the incidence of the AIDS when it was a death sentence
incidents, yeah.
and the current situation in which it's no longer necessarily a death sentence.
Okay.
And the behaviors.
Yeah. Well, I mean,
What leads to its incidence?
well, it's been. There's several studies that sort of have looked at that. Some have shown that as people became relaxed about sexual behaviors, young gay men who hadn't experienced the whole thing have now started increasing higher risk behavior. So in our country, so that's an issue. There's still X percentage of people, 20% of people who are infected don't know that they're infected in our country. That's why there's a large campaign for testing. But I think in Rwanda or in the country, in developing countries, I think the issue is that people want to take therapy. People do well on therapy. And I think the more people you have actually on therapy whose viral load is lower, the less likely, both by behavior changes, knowing someone's infected and therefore they would change their behavior and not put someone else at risk, as well as the fact that their viral load is so low so they actually will not put someone else at risk. So that treatment is important in several ways, not the negative way that you're thinking about it.
Is there a difference there between the U.S. and Africa in that regard?
No, I think probably Africa is going to be moving in that same direction also, except for the fact that only such a small percentage of only 25 to 30% of the people who should be on therapy are on therapy. And the numbers that we're talking about, the implications of how many people will new 2.7 million new infections a year, and that will probably continue. 450,000 children born with HIV last year. I mean, you're just talking about overwhelming numbers. So, yeah.
There's two questions. One, I've asked you before, I know, and it still haunts me.
That means I didn't answer it well.
Well, no, I don't know. In situations where poverty is so prevalent and violence and lack of economic opportunity, et cetera, what does it mean? I mean, are there cases where we're extending suffering by extending life? And I know it's a terribly awkward and uncomfortable question to ask, but is there a dialogue around that in really resource-poor areas, or is the value always to live longer, even where life is very, very difficult?
I think this goes to an ethicist rather than me, but I think I know it's a really, well, it's the right discussion for this group.
I mean, it's a great question.
I'm not saying we shouldn't.
No, we heard you. Yeah.
So what does it mean? If you don't, I mean, we ask this question when we talk about end-of-life care. At what point are we extending suffering with interventions, and for whom are we extending a quality of life?
Well,
I would answer with the hue and cry for additional therapy in every community, no matter what the incidence of tuberculosis and HIV and violence.
Yeah, they're desperate.
What people ask for is treatment and prolonged life. And
even where the circumstances of
absolutely,
life are
absolutely. So
yeah, I mean, you think about.
It's different than,
Well, but no, I'm not saying therapy clearly works, but you've made an argument for how much suffering there is outside of HIV/AIDS.
Oh yeah, well, to me, I didn't make the argument to say that we shouldn't address it.
No,
I mean,
so.
know that. I mean that, it's addressable. It's totally addressable. I mean, the disaster that just befell Haiti wasn't just that earthquake, right? It was because we ignored and oppressed it and prevented resources from being in that country since people rose up. So, I mean, the fact that we can do something different, I think that concept of it's not, it's things are changeable, that there is a way for there to be difference, which I know you believe, or it's just sort of very strong for me to say that that's worthwhile to continue that. I think that's very important.
So can I ask the other question?
Okay.
Which is I've been struggling with this also, which is the value for fairness. So you started the talk around, and the literature around disparities and why disparities are a problem is very, IOM says disparities are wrong because they are unfair and that needs to be corrected. And that speaks to me, but it seems to me that the gap between the reality of disparities and the resources to address them is maybe heavily explained by lack of a universal value for fairness. I mean, we live in a society, a democratic society, yes, but a capitalist society where there's value in unequal distribution of resources.
That's why I think the structural violence argument is so important, because it actually says that is the reason why, that there are reasons for these things to be true. I mean, that they are true, not to be true, but that explain them. And if those things are addressed, then we have a different sort of agenda, and we have different sort of things that we have to do every day, and different things we have to do in the long run that actually could challenge that to make a difference. I mean, we see volunteers come all the time to our program and other programs, medical students, college, post, and it's, it's very hard to figure out how to sort of engage them to not just want to sort of just help at that moment, but actually see the reasons for why things are happening so that their agenda becomes larger. to actually address the structural violence issues. So I think that's why that framework is so important.
I'm interested in knowing whether how successful you are, or whether you're actually engaging some of the government of Rwanda in terms of, educating the masses about the issue of HIV, because it seems as if it's probably unsustainable to keep giving people therapy when millions and millions are getting infected every year.
The Rwandan government is extremely on board and spends all its energy. It's like a poster child for doing HIV care correctly. It could be the poster child in part because 99% of the resources that it uses come externally. And it's much easier to be perfect when you have the resources to do it. So those countries that in fact are self-supporting more are not doing as well because there aren't enough resources. To me, it's a reparations issue, actually. I think sort of that a lot was taken from that continent, particularly, specifically, and a lot has to be given back.